clinical chemistry was being considered, but it hadn't been formed. So I'm absolutely delighted to see that your society has been so successful, and I congratulate everybody who's been involved in bringing about that success. As you've heard, today I want to discuss the future of laboratory medicine in a changing world. This is a general presentation from, I guess, a personal perspective that's been developed over many years of working for IFCC. I want to start with a few general slides to set the context for the rest of the talk. This is a slide I show at almost every talk I give because it highlights the central role of laboratory medicine. Laboratory medicine influences a high percentage of all clinical decisions. We're involved in identifying risk factors and symptoms, in diagnosing disease, in determining appropriate treatment, and in evaluating the response to that treatment. So we truly are central in healthcare. But with that central role, of course, comes a huge responsibility to ensure that the product that we deliver, the quality of the laboratory medicine that we deliver, is as high as it can possibly be. The second bit of context I want to give you is that over the last 10 years or so, laboratory medicine has been under review in most, if not every country in the world. The terms of reference of those reviews are all different, but they really contain the same three elements. The first one is quality, and we are being challenged to improve the quality of our product. That involves analytical quality, of course, but it also includes quality assurance and perhaps moving towards laboratory accreditation. At the same time as we're improving quality, we are being challenged to be more effective in clinical terms. That means, can we actually help to improve the clinical outcomes for patients? Can we provide a service which is more patient-focused? And can we provide a service which is more timely? And then the third element that's in any review, of course, in the current environment, is cost effectiveness. Laboratory medicine specialists have been very effective in looking at how we can contain the total cost of our service, increasing the value for money, and looking at the most appropriate use of our laboratory. Now, we'll come across all of these elements in the next few slides. Now, I first showed this slide more than 10 years ago. And at that time, it was thought to be fairly radical, because what we were saying was that the development, the future of laboratory medicine contained these same three elements. So we were having to develop continuous laboratory quality improvement, and at the same time work to improve clinical outcomes, and at the same time try and improve efficiency and cost effectiveness. And we took a very simplistic view that we know all about laboratory quality inside the laboratory, but if we put a little red box around the other two, we can maybe say, well, if we work on those, we are adding value to the quality service that we contain. Now, as we'll see, the concept of adding value has moved on quite a bit in the last 10 years. What was important, though, when we showed this slide 10 years ago, was the realization that our future lie outside as well as inside the laboratory. And here's another little bit of context, but this time not from laboratory medicine. This dates back to 2012, and it comes from the Harvard Business School. And what they did was they got a group of businessmen and businesswomen together, and they said, let's try and predict where the future of healthcare lies. What are the mega trends in healthcare? And because they were business people, this meant, where are we going to put our money into the future of healthcare? And they came up with these 12 big areas, and I've just set them round a clock to give some concept of moving forward with time. And I've maintained the colours from the previous two slides. So if we start at 12 o'clock, they thought that the future was going to involve dealing with an aging population and the chronic disease that's associated with that. Embracing technological advance and personalised medicine, recognising innovation and the demand, especially from emerging countries, taking on board evidence-based medicine and clinical practice guidelines, accepting environmental challenges to improve the quality of our water, our air, our food, and perhaps to help to avoid congestion in major cities. They identified global pandemics, and boy did they get that one right. And the final one that's shaded yellow there was they recognised that more and more we'd be looking towards prevention of disease or wellness screening. So those areas all highlighted in yellow are all about improving clinical effectiveness and clinical outcomes for patients. The other areas that the businessmen recognised were that more and more care provision would be done by non-medically qualified personnel, so non-MDs providing more of the care. They recognised the growing role for philanthropy, particularly in developing countries. They recognised more and more that payers, in many cases that means the patients, are going to be influencing decisions. And the concept of well-informed patients was recognised. Almost the last one now is the idea of medical tourism, where patients would travel abroad for treatment. And then finally, inevitably again, recognising rising costs in healthcare and inadequate budgets. And you can see that those 5 areas are all coloured pink because they're to do with cost effectiveness. Now that slide was put together, as I say, in 2012, and I think we've now had 8 years to see how good the predictions were that these businessmen and businesswomen made. And I hope you'll agree with me that they were all extremely accurate. And not only that, but that laboratory medicine has a major role to play in all of these 12 areas. Well, so much for that context. Let's now look at some drivers for change in laboratory medicine. There are many, and today I'm really only going to have time to discuss 6. The 6 that I'm going to discuss with you are technological advance, globalization, smarter ways of working, integrated diagnostics, patient-centered care, and a return to adding value to improve outcomes. Now, each of these topics is huge and could easily merit a lecture in its own right. So you'll understand that I can only look very briefly at each one. Let's start with technological advance. And this is one where I suspect everybody will feel fairly comfortable because it's an area that you understand. I've just picked out 6 here. There are probably many more technological advances that could be put on a slide. But we must start, of course, with the whole omics revolution. So genomics, proteomics, metabolomics, and many other omics are changing a great deal of modern medicine. And of course, laboratory medicine is hugely involved in the whole omics revolution. In some ways linked with that is the massive change in informatics, whether it's health informatics or bioinformatics. And we're now familiar with the concept of big data and trying to manage big data. If we move inside the laboratory, then we're seeing ever more growth in areas of automation and robotics to handle the high throughput workload that we're seeing. At the other end of the spectrum, we're also seeing a growth in nanotechnology, taking things down to a very small scale, and we now see laboratory medicine and wearable devices and implantable devices. Point-of-care testing has been with us for many years, but it's now really taking off, and we're seeing diagnostic testing of laboratory medicine taking place in many different clinical centres. And then finally, I've put on mass spectrometry. It's been around for a long time, but we're now seeing a revolution in low-cost mass spectrometry with specific applications, perhaps most notably in microbiology. Now, there will be other technological advances as well, but if we look at them all together, then quite clearly they're exciting, but they provide a challenge to us in terms of our ability to embrace them, and indeed in our ability to train the next generation for being able to manage these new technological advances. In some ways, this slide says the same thing. This is a slide from a good friend of mine, Larry Kritschke, who was working with me in IFCC at the time. And he wrote a review entitled The Future of Laboratory Medicine, a 2014 Perspective. And he highlighted 12 areas for the future of laboratory medicine. And if you look at them, 10 of them, in other words, those other than organisation and staffing and evidence-based medicine, the other 10 are all technological in nature. And so, again, it's reinforcing just how important to us technology is going to be in the changing face of laboratory medicine. And we have to rise to the challenge of embracing that technology. The second area I want to touch on will be familiar to you, but maybe you haven't thought about it in the same depth. And that's the idea of globalization of laboratory medicine. As this talk is demonstrating, we live in a world of instant global communication. And that means that things like quality standards, laboratory practices, and clinical applications can be communicated instantly all around the world. Now, that on the face of it is good because it should facilitate uniformity to aid improved outcomes. If we're all doing things in similar ways, then that should surely help to move forward in terms of the overall clinical improvement. The problem is that globalization has also highlighting differences in practice, and that's probably where we are just at the moment. If we look at this slide, here are just some of the issues that need to be handled as a result of globalization. So different methods give different results on the same sample. We're employing variable units in the results that we report. We're using variable reference intervals for the same measurements, and there's often no justification behind those different reference intervals. We have many clinical practice guidelines that rely on laboratory medicine results, and there's huge variation in those clinical practice guidelines. And finally, there are innumerable international directives and regulations that impact on laboratory medicine. They are complex and very difficult to come to terms with. So these are not trivial matters. They are serious challenges in terms of embracing globalization, and we need global solutions. And probably the way forward with globalization is a recognition that we need greater harmonization. And this is a particular topic that I feel very comfortable with. And again, if we look at this slide, we can start maybe with terminology. What do we call tests? Many labs call the same test different things. Recipe for confusion. Which units do we use? Well, I would suggest to you that we should always be using SI units when we can, because non-SI units are subject to variability in terms of the purity of the calibrators that we use. Which test profiles do we use? Should we have specific profiles for investigating specific disease entities? The problem of reference intervals. We're all using different ones, and people can go online, they can look up their result, they can look at a reference interval, and it may be the wrong reference interval for their particular result. We need to harmonize decision limits so that we're all agreeing that if a result is at a certain level, then the decision is that we should take this next particular clinical step. We should be seeking to harmonise report formats. Our reports should all contain essential information, of course, but should we agree what additional information, things like clinical details and cumulative reports and interpretation, should they also be included on our reports? We should try and harmonise interpretation criteria so that if we're presented with a set of data and some clinical details, we can agree what they actually mean. And then finally, and by no means the least of our problems, is the issue of measurement procedures, that of different methods giving different results on the same sample. Now, all of these are part of harmonisation, and if you're interested in harmonisation, I refer you to the many publications by my good friend Mario Plebani. The third driver for change is smarter ways of working. We've already heard that we have an aging population with more chronic disease, and that there are medical and technological advances. And I'm sure we're all familiar with the idea that our workloads are rising. So all of these things are putting pressure on healthcare budgets, and that includes laboratory medicine budgets. And therefore we've got a responsibility to try and manage to provide an ever-increasing quality of service whilst containing the costs that we are having to experience. And there are many ways of doing that, and I've highlighted just 3 in this slide. The first is trying to improve our efficiency, so we're doing more for the same, or maybe even reducing the amount of resource that we are using. Workload management means trying to make the most appropriate use of the laboratory so that we're not doing too many unnecessary tests. And then sharing resources. Does every laboratory need to have a piece of equipment that it's only using for 2 hours a day? Should we actually be sharing our equipment with others to make best use of these expensive capital items? Now, no matter how we look at smarter ways of working, there will be impact on the staffing levels that we have in the lab and the skill mix of the staff that we use. And I'll return to that in just a few slides. Now, it used to be that we thought of laboratory medicine being provided essentially from a central laboratory, and that was really the only clinical setting where clinical laboratory medicine was provided. Now, of course, we're getting laboratory medicine provided by many different clinical settings. So satellite laboratories, hospital clinics or wards, primary care surgeries, specialist laboratories, acute medical receiving centres, and even operating theatres are now providing laboratory medicine testing. And of course, we shouldn't forget that increasingly high street pharmacies, the workplace and the community, and many patients' homes are now actually settings where laboratory medicine is undertaken. We, of course, are the experts in clinical laboratory medicine and testing, and we can't really ignore all these centres outside our immediate vicinity that are providing testing. So we do have a responsibility to try and communicate with users of laboratory medicine services in all settings. It's challenging, but it is part of our responsibility. Now here's the concept of a hub and spoke network. I'm not sure what the state of networks is like in Saudi, but in many countries, including the UK, the concept of a network of laboratories is now very real. What this means is that you have a central laboratory and a number of peripheral laboratories. They all have the same operating systems, the same standard operating procedures, the same informatics systems, the same reference intervals and so on, and they can be accredited as a single laboratory network. What this means is that the high throughput work can be done close to where the patient is in peripheral laboratories. The more specialised work can be sent to the central laboratory for efficient processing. And both the central laboratory and the peripheral laboratories are doing and managing point of care testing. And a small amount of the highly specialised work, of course, is sent on to national reference laboratories. Now, there have been some studies that have shown that you can get an improvement in turnaround times following a move this hub and spoke model of delivery. Essentially, you are doing testing more quickly, and that's got to be a good thing. Now, here's a little bit of a study from 20 years ago from a colleague of mine that highlighted the rationale for workload management. This is called test utilization in North America. And what my colleague did was he said, okay, well, our laboratory serves 22 different general practitioner services. Let's work out the number of tests per 1,000 patients for each of those general practitioner services. Now, you might expect that GP services would be broadly similar, but here you can see there's a more than 10-fold difference between the general practice that used most of our laboratory services and the one that used the least. Now, what that means, of course, is that some GP practices are probably doing too many tests, and some GP practices are almost certainly doing too few tests. Where's the optimal use of the laboratory? Well, it lies somewhere in the middle, between overutilization and underutilization. How do we determine what the optimal use is of the laboratory? Well, that needs to be evidence-based, and it needs to take on board things like clinical practice guidelines. And it's perhaps a challenge for local laboratories to try and work with their users to narrow this 10-fold gap in workload management. And then we return to the issue of staff skill mix, because this is such a sensitive issue. At one and the same time, we're seeing laboratory staff being trained to a higher standard. That means they're better quality staff, but they're costs more to train and they expect to be paid more. Whilst that's happening, we're seeing the introduction of automation and robotics that are reducing the skill level required of many of our staff. Technology is taking over the roles of some of the skilled roles that our staff traditionally have undertaken. So this is a very delicate balancing act to try and get it right. And really, we are going to have to adjust staff numbers and skill mix as a part of smarter working. Difficult to do and taking time, but it's not something that we can actually ignore. Whoops, here we are. Okay, our fourth driver for change at the moment is the concept of integrated diagnostics. We, of course, are familiar with laboratory medicine, and we know that imaging and endoscopy exist as other diagnostic services. Now, until relatively recently, these diagnostic modalities really only ever came together when the results were in front of the doctor and the patient. But more recently, the concept of integrated patient pathways has grown up, where we can actually use the diagnostic services in a integrated way to speed up the patient journey. Now, what this means is that we have to have an increased reliance on informatics and knowledge management. And it also means that we were challenging the erosion of some of the traditional boundaries of laboratory medicine. The next slide gives you that in a little bit more detail. Here's the concept of a patient journey, an indicative patient journey from diagnosis through treatment to follow-up. And you can see we start with presentation and we finish with the patient outcome. And there are many, many steps involved in between in this patient journey. And as the clock says, this takes time. And time, the more time you take, the less efficient it is. Now, the boxes that are highlighted in purple are areas where diagnostic testing can take place. That diagnostic testing may be laboratory medicine, it may be imaging, or it may be endoscopy. And what we need to be able to do is to have a very clear patient pathway for each particular clinical disease pathway that's being investigated, so that we know what tests need to be done when, and when the results will be available, and how they can be looked at, and how we can then move on to the next stage in this diagnostic testing patient journey. That's quite difficult. It relies on us working with our clinical colleagues, but again, it's something where we can actually make a significant contribution. And one way to embrace that is through the concept of the multidisciplinary clinical network. This is something that's now quite popular in the United Kingdom. So what we have is we have an MCN for defined clinical conditions. It might be breast cancer or diabetes or broad clinical areas. And this network then has input from all of the key stakeholders. So they would include all the medical staff, for instance, like general practitioners, specialist physicians and surgeons. Increasingly, they will also have input from patients. So the patient with breast cancer has an awful lot to contribute to understanding how we should be investigating breast cancer as a disorder. But of course, the diagnostic modalities should also be involved in this network. So laboratory medicine specialists and imaging and endoscopy specialists should also be involved in the network, as indeed should pharmacists, because very often the use of drugs is part of the management of the patient. So if you can get all of these people together to agree how a particular disease condition can be investigated, then you're well on the way to having everybody speaking from the same page and having a much more efficient investigation of that disorder. And laboratory medicine specialists really must be part of this network. The fifth driver for the future is patient-centered care. And this is becoming really very important at the moment. And I've divided this really into two areas. There's the individual patient, which really means personalized care, where you're aiming to optimize the response for the individual patient. And then there's the informed patient, who knows an awful lot about their condition and where you're hoping to engage him or her in the management of their own care. So this is patient-focused care. I've shown this slide for a number of years, but I think it's still very relevant. We're moving in a new direction for medicine. We're moving from reactive medicine to precision medicine. Reactive medicine is population-based, symptom-based, therapeutic, and the patient is largely passive. Precision medicine, or 4P medicine, is personalized, predictive, preventive, and the patient is an active participant in the management of their own condition. Now, what is it that's driving this change from reactive to precision medicine? Well, it's being driven by new, high-quality diagnostics. And these diagnostics are very commonly linked to individual genomic variability. So laboratory medicine is really at the heart of this changing direction in medicine. And that's perhaps illustrated by this slide on companion diagnostics, because we have a growing number of diagnostic tests that have been designed to elucidate the efficacy and or safety of specific drug or class of drugs for a targeted patient group or subgroups. So what that means is that you cannot give the drug without performing the diagnostic test. The two go absolutely hand in hand. Here are just 4 examples that have been around for a while, but we're seeing more and more diagnostic tests. Often these are genetic markers or genetic mutations. More and more of these tests are an essential part of some of the modern and very expensive companion diagnostics and the therapeutic drugs that are being used. If we then change to patient-focused care, this is an interesting study that I was part of that was published just last year, entitled The Role of Laboratory Medicine in Collaborative Healthcare. And this was an opinion paper put together by a couple of people from laboratory medicine, together with a very innovative general practitioner and a lady who is the chair of the UK National Association for Patient Participation. So a very high-ranking champion for patients. And to summarize an interesting review, we came up with the concept of a tripartite collaboration, whereas the clinician, whether it's the GP or the hospital doctor, together with the laboratory medicine specialist and together with the patient, are all involved in the management of the laboratory medicine results and interpretation and further action for individual patients. And the general practitioner in part of this makes all of his results available to individual patients, invites them to see them, provides them with clinical information that they can actually seek, and provides a helpline. And the laboratory has been an integral part of providing that support for individual patients. And that is a very challenging area for us going forward, but it certainly, I think, highlights the role of laboratory medicine outside the laboratory as we go forward into the future. And then finally, we're returning to this concept of adding value. I showed you a 10-year-old very simple slide that suggested that adding value was all about increasing clinical effectiveness and cost effectiveness. Well, a few years later in IFCC, we took it to the next stage, which was to develop this very simple mnemonic, where again we've got the quality of laboratory medicine in the center driving everything else. Increasing quality drives everything else. And then we said, okay, well, we can put 6 spokes on the outside of this wheel, and we can call them, we can give them the mnemonic science. So they relate to standardization, harmonization, clinical effectiveness, innovation, evidence-based medicine, and novel applications. And that's our clinical outcomes and clinical effectiveness, and then cost effectiveness and educating others in the appropriate use of the laboratory relates more to the cost effectiveness side of things. So that again was a model that people picked up and used because they thought, well, it's simple, I can understand what value may start to mean. And at the same time, we put together another very, very simple tool for assessing the value of laboratory medicine. And this was, no matter whether you're in screening, diagnosis, treatment, prognosis, or monitoring, what you're aiming to do with laboratory medicine is you're aiming to optimize the outcome for the patient whilst getting the best possible operational or cost efficiency and giving the patient a really good experience. And of course, if you, for instance, shorten the patient journey, that will improve the patient experience. And so these 3 prongs to try and assess value of any change in what you're doing in laboratory medicine was again accepted as a very simplistic but understandable way of considering value. Then things started to move on, and we got a lot more evidence-based and a lot more scientific when we were thinking about what value in laboratory medicine means. And a former president of IFCC, Howard Morris, led the concept of the value proposition to try and, in a evidence-based and logical way, assess whether we really are providing additional value to laboratory medicine in terms of helping with clinical outcomes and maybe cost effectiveness. Now, this has got a lot more scientific, it's got a lot more complex, and so the simplistic models that I was providing have really been overtaken by science, and I can openly admit that today's Today's experts are far more expert than me. And just to bring this entirely up to date, just last week, I don't know if anybody participated in this, but IFCC had a live webinar last week on the value and impact of laboratory medicine in patient care, developing the evidence. And this involved the current IFCC president, Khosrow Adeli, together with probably the 2 world experts in laboratory medicine and value. That's Andrew St John from Australia and Paul Juliker, who works for Abbott Diagnostics and is based in Germany. And they produce some really exciting visions for the future, but they are really challenging for us, because if you think of patient outcomes and cost effectiveness as being a rather like a jigsaw puzzle, then laboratory medicine is maybe only 1 or 2 pieces in that jigsaw puzzle. And being able to demonstrate that those 1 or 2 pieces actually change clinical outcomes and cost effectiveness is really very difficult. So it's an area that's going to grow and become more important for the future. I just put in a plea that we've got to try and maintain some level of simplicity whilst accepting that there is a need to be more and more evidence-based. So that moves me to the final part of my talk, which is how could we respond to the changing world of laboratory medicine? And again, with my trend towards doing things in simple terms, I've got a very simple one-slide summary. It's probably oversimplistic, but I think it again is helpful just to get our minds around the challenge that faces us. And I'm suggesting to you that the response to the identified challenges lies in three areas. It lies in getting our education and training right, it lies in improving our communication, and it lies in better leadership for our profession at local, national, and international level. Now, of course, each of these areas is enormous and again could be the subject of a lecture in its own right. But we'll have a look in brief at each of these three areas. And this, to my mind, is probably the most important. Education and training fit for purpose. And I stress the fit for purpose. That's really the most important term on this particular slide. And I'm suggesting to you that education and training in laboratory medicine needs two major components. It needs knowledge and information, which is largely taught. If you like, that's education. But it also needs practical experience in the workplace where we develop skills. And that perhaps is more in the area of training. And what we need to embrace in both of these areas are the 6 things that are in the middle. Now, down the left-hand side is what you might expect to see. So we need to be educated and trained in technical, scientific, and clinical areas of laboratory medicine. So all the applications, the scientific principles, innovation, normal pathology and pathopathology, all of these things are part of our training, and they're the areas you would expect that we should embrace. In addition, I think modern education and training should also involve improving communication. It should involve leadership in management, and we've already mentioned those two in the previous slide. But the final thing it should include as well is professionalism. Laboratory medicine professionals should in fact be behaving as true professional members of a healthcare community. So this includes things like ethics and probity and good governance in the way that we run the services that we oversee. Now, there are 2 more really important areas to note on this slide. On the left-hand side, suggesting to you that education and training has to be delivered and assessed by peers. It has to be done by people that know about laboratory medicine and are capable of assessing it in an appropriate way for the future of our profession. All too often in the past, we've had didactic teaching by university people that have never been in a clinical laboratory. And that really isn't acceptable as a way forward for education and training for the future. And then on the right-hand side, we've got the concept of the clock again, and the idea that we should be updating our education and training all the time, continuing professional education, continuing professional development, or lifelong learning. It has many names, but we should actually always be learning. And we should actually perhaps introduce schemes that encourage us to keep learning and maybe even assess whether or not we are keeping up to date. So there's a lot in the whole area of the future of education and training. There's some help at hand, and here are a couple of papers from 2018 that suggest that we're getting international agreement on what the content of a syllabus or a curriculum should actually be. Both of these papers contain a lot of detail, and they take on board some of the points I made in the previous slide. The second big thing that we can improve to try and respond to the changes in laboratory medicine is communication. And I can't think of anything that has changed as much in the last 10 to 20 years as communication. And of course, it's continuing to change all the time. So communication has never been easier. We've already heard that modern communication is global, it's instant, it's inexpensive, it's readily shared, and it's multimedia. And that's all good. However, one consequence of that is that we all suffer from communication overload. So the trivial can often obscure the important. And we should never forget, really, that effective communication involves getting the correct information to the correct recipient in the correct time frame and in the correct format. The next couple of slides just give you some examples of that. So if we think in terms of the local laboratory where many of you will work, here are some communications that should be person to person. So those things that are patient related would be pre-analytical problems, critical values, urgent results, reflex testing, clinical discussion of a patient, or a follow-up strategy. Other issues that require person-to-person communication are specific safety issues, appropriateness of testing, complaints, and errors. Now, person-to-person communication doesn't always mean talking face-to-face, but it does mean that one person is talking to another person to make sure that the communication chain is as short as possible, because these areas require follow-up in a short period of time. Conversely, there are a number of other communications that can be available for access at any time by users. We don't need to be directly involved. We can provide the information for people and they can access it when they actually need it. So in terms of patient-related communications, this would include the repertoire, sample requirements, when scheduled results may be available, what typical turnaround times may be, what operational procedures are, investigative protocols, reference intervals, clinical guidelines. And you may want to share with people the strategic plan for the laboratory or your quality performance parameters. And this information is always available, and again you can see there are a number of different ways in which you can provide that. And please don't forget the helpline. If all else fails, it's useful to have somebody that can provide help on the end of a phone if a doctor is struggling and needs direct help. If we come to national and international communication, essentially they're two very similar things. Who needs to communicate? Well, obviously laboratory medicine organizations, and they need to communicate with clinical organizations, the diagnostics and healthcare industry, increasingly with regulators and policymakers, and especially going forward, more and more with patients and the general public. How could we communicate? Well, there are a lot of media there that will be well known to all of you, and there's nothing particularly revolutionary in those. It's just how we choose to use them. But that does raise the interesting suggestion to you: is there any future for face-to-face conferences? Here we are having a virtual conference, and I've no doubt that it'll be highly successful. There are advantages in virtual conferences. The technology is improving, and so they're very simple to organize. They're inexpensive to run, and it's a very efficient use of participants' time. And the presentations from these virtual conferences are available instantly and globally. There are, of course, some disadvantages. Reduced opportunity for informal networking that you get by attending face-to-face conferences, reduced contact with the diagnostics industry, and that's something that I feel is particularly something that we should be trying to avoid. And then, of course, there's the financial challenge from the organizations that have been running face-to-face conferences, and relying on them for a source of income for running the services that they provide. And the final area in terms of how to respond to the future is getting our leadership right. Now, I've really only put up one slide on this because there is an enormous amount of information available, excellent education and training support for leadership, coming in the form of webinars and conferences and courses and lots of different media for providing leadership training. My main point to you is that as laboratory medicine specialists, we should embrace leadership training. In my mind, this involves a leader is someone who has vision and strategic direction, someone with effective communication and the ability to inspire others, someone who can listen to information and evidence and then perform critical analysis of it to take appropriate decisions, someone who is decisive but is also flexible and willing to admit that they need to change direction if circumstances change. A leader is also someone who's good at delegating and empowering others to be part of the leadership team. And finally, a leader is someone who is good at innovating, directing, and evaluating products. That doesn't mean that they actually perform them. It means they start them, they oversee them, and they evaluate the outcome from them. And it's linking to that, the final comment at the bottom there, leadership does not include operational management. Leadership and management are both essential, but they are fundamentally different, and we need both in laboratory medicine. So, trying to pull all this together now as I close, what does this mean for your laboratory and for the Saudi Society for Clinical Chemistry? Well, obviously all laboratories and all national societies are different. They must evolve to meet local circumstances and needs. So the one-size, off-the-shelf solution is not going to fit everybody. It means, therefore, that leadership is required to agree local plans and policies, and I'd suggest at national level, national plans and policies. And that leadership will involve getting agreement from key stakeholders, including users. Now, having said that, there might be some merit in an outline leadership plan to start the discussion of how you're going to adapt it to meet local level. And so my penultimate slide I show with a degree of trepidation is a sort of outline leadership plan. And we're returning to the idea of the format that I use for the Harvard Business School. So if we start at 1 o'clock, what can you do to respond to the challenges for the future of laboratory medicine in your laboratory or in your society? Well, you can optimize the quality of your service. You can gather evidence of your clinical effectiveness. You can gather evidence of your cost effectiveness. You can apply the value proposition to your service, and you can encourage discovery and innovation. You can adopt novel and improved technology. You can share and evaluate examples of good practice. You can make your service more patient-centered. You can collaborate with other laboratory specialists, and you can implement new ways of working. And of course, you can optimize your local communication. And a final plea, the one at the top there, please, whatever you do, promote the contribution of laboratory medicine to healthcare. Remember, we have a central role. And so my final slide is just to give you two quotations from two of the more visionary recent presidents of the United States. They relate to change. Some of us find change difficult. So let's start with John F. Kennedy, who said, "Change is the law of life, and those who look only to the past or present are certain to miss the future." And coming right up to date, Barack Obama said, "Change will not come if we wait for some other person."
Thank you so much, Dr. Bistos,
we
for
are
the
the ones
wonderful
we've been waiting
presentation
for.
about the future of laboratory medicine in a changing world.
My time is up in more ways than one.
We have some questions. The first one, actually,
over to you, and I wish you every
How can we
success in the
address the
future.
needs for skilled and non-skilled lab technologists in front of advanced and sophisticated lab automation? Yeah, how can we address and assess their need, especially with the current transformation and advances?
Right. So lab technologists, what was the issue? Was it how do we train them? Okay. Right. Well, you obviously need to decide the direction that your laboratory is going in first, and at the same time, you need to look at the staff mix and the staff skills that you actually require to deliver that. Now, I'm not sure whether you have an organization for laboratory medicine technologists in Saudi Arabia. I mean, certainly in UK, we have a very active and dynamic society who are responsible for training many of the technologists, and we work very closely together to actually supply the appropriate training. And a lot of this training has been done through conferences, but I think now will be done more through virtual conferences and through training courses. So you may well have training course on a particular technology and how it can be used and how it can be applied, or you may have a training course on interpreting results in a particular set of clinical conditions. So it lies in education and training as one of the ways to respond, and of course we can only do that if
Thank
we
you, Dr.
communicate
Graham.
properly.
For the sake of the
I don't
time,
know if
we
that
can
helps
also
but I
ask
think
another
it's a
question here.
multi-stakeholder involvement.
As the practice of
but you first
medicine
have
is
to
different
identify
across
the
the world,
need.
does
What is it that you're
IFCC
trying
has
to
any role in developing some
provide support
guidelines to
for,
guide
and then
labs across
decide
the world?
how and who that support's going to be provided by. Yeah, I mean, IFCC spends a lot of time developing guidelines, and you're absolutely right. Practices do differ across the world. I mean, when I was president, started as president in 2009, there were no regional federations, or at least no effective regional federations for laboratory medicine. And we recognized that the first thing that we could do would be to create and empower regional federations to try and become more in touch with the local needs of laboratory medicine. So there are now 6 regional federations of IFCC, and you mentioned in your introduction that the Arab Federation is the one to which SSCC belongs. And I think the idea behind these regional federations is that the members should all meet together and try and identify the priorities for your own particular region and actually try and put together a program.
Thank you, Dr. Graham, for the excellent presentation and for accepting our invitation to be the keynote speaker in our conference.
I have to say some of these
actually we are exactly on time,
are more active and
so
more effective than others.
We are moving to the first session under the
direction.
theme of laboratory management, moderated by our colleague, Dr. Nashat Nafouri. Thank you, Dr. Graham. Thank you.